Thank you.
Now, can we have our next speaker, Dr. Mohit KHATTRI? He would be presenting on cataract surgery in diabetics, key perspectives.
Good morning, everyone, and I'm very much thankful to AIOS for giving me this opportunity to share my few cents on a very basic topic. What exactly I want to emphasize here that today cataract surgery and diabetic retinopathy, they have a very complex interplay between each other, and it's not a solitary act which one has to perform. It's an interplay between two surgeons. It's a complex mechanism, and we should respect the phenomenon of diabetic retinopathy going along with cataract surgery. Doing cataract surgery is not just one job being done. You need to give space to the other surgeon, and medico-legally it is going to be very important. We have to document and we have to manage diabetic retinopathy along with cataract surgery. So when you see the patient in your OPD, just don't look at the blood sugar levels. One important thing is see if the vision has dropped suddenly or it has been a slow process. If it is a rapid onset or a sudden phenomenon of drop of vision, have a red flag sign. And if everything looks normal also, take the history of anti-VEGFs, lasers or any retinal surgery being done in the patient. Or if the patient has been using some anti-glaucoma drops. If there are comorbidities, again, you have to be very much alert. When you examine your patient, don't just see diabetic retinopathy and cataract, see the ocular alignment of the patient also, and be very careful at the lid margin. These are the areas where the problem arises. One has to be very, very cautious about the pupillary dilatation and see the patient undilated also for any subtle signs of NVI. Don't have to ignore them, and don't just see the macula and the cataract, have a very critical look at the disc also. Sometimes optic neuropathies keep hiding and then you have a suboptimal outcome of the cataract surgery. When you investigate, just don't see blood sugar, fasting PP, have your HbA1c done, and AIOS task force says that fasting blood sugar less than 140 and RBS or PP less than 200 will suffice, but have your own protocols. Do an FFA if the best corrected visual acuity is not corresponding with the cataract. OCT is must, but FFA has to be decided. If needed, go for it. B-scan, specular, all that is optional. Be very careful with biometry if the patient is having vitreous hemorrhage or an oil in situ. And if a single-eyed patient is there, then only go for a conjunctival smear. Don't consider any fancy ringed IOL in such patients. Always prefer a single piece acrylic hydrophobic IOL. EDOFs are okay. Toricity needs to be respected. When you are operating, it's very important that you should be well versed to deal with a small pupil. You need to have your pupil expanding devices at the backup, or you need to be well versed in managing through small pupil. Don't make a small capsular excess. You need to have space for the other surgeon also to look into the pupil. Thereafter, maybe lasers are needed, surgery is needed, so there is no space for capsular phimosis. Don't have residual cortex. Try to have all the maneuvers done in the bag, and so that you don't need to have to give to oral steroids and all other things, and don't decompensate your cornea thereafter. Always give intracameral antibiotics and ensure a watertight closure. Post-operatively, if you go by science and the published data, many of these patients have a subclinical CME developed. We don't go for an FFA out there after cataract surgery. If all is going on well, who investigates? And yes, it's rightly done. But these patients need a longer follow-up. I prefer to give them a long-term NSAID drops to prevent all these things. And then if anybody comes up with a suboptimal vision after cataract surgery, don't just ignore. Go for a follow-up OCT and see what's happening. Important case scenario is if you have a cataract patient with NPDR with no involvement of macula. This is going to be a routine case. Go and operate. Just have a longer follow-up. Optional to see a follow-up OCT after 6 weeks of cataract surgery and give a long-term NSAID drop. Now, if you have a patient with cataract with NPDR and a CSME, I prefer to dry up the macula first. If the media is clear, try to dry it up, give anti-VEGFs, maybe a focal laser, and then do cataract surgery. Don't be in a hurry to jump for cataract surgery, it will worsen it. And if the media is very bad, you are not able to see the macula and all, then do a cataract surgery combined with an Ozurdex, and then analyze the situation thereafter and take a call. If you have a PDR with cataract, this is important. So look at the macula, do an OCT. If there is a traction involving macula, then it is going to be a phaco with PPV with laser. But then if traction is not there, then you can go with phaco with anti-VEGF and quickly do a PRP as the media permits. So what not to be done is just doing cataract, having a good post-op follow-up for a month and referring to a VR surgeon. That is going to be digging a grave for the patient. So what not to be done is more important. We don't have to do cataract surgery plain for a PDR patient. If you have a PDR with cataract, manage PDR along or before jumping into cataract surgery. Now a patient comes with a mature cataract and a vitreous hemorrhage. Never miss an NVI. If you're sure that there is no NVI, what my preference is a combined surgery or cataract with an early vitrectomy. We don't have to again wait for a month and then refer for a vitreous hemorrhage treatment. If you are planning a combined surgery or if you are well versed to do the same together, it's best. If not, then suture the wound and within 5 to 7 days go for a vitrectomy. So if there's no traction, I'll give an anti-VEGF with phaco, and third day or within the 5th day a vitrectomy is going to be done. If not, then together. So the most difficult part, if there is cataract with NVI, first of all document, image, show it to the patient that this is not going to be simple. If media is good, do laser, laser and laser. As far as possible, try to laser, indent, do an LIO and then give an anti-VEGF and then do cataract surgery. If media is bad, this is the worst case scenario. Give anti-VEGF and plan phaco plus minus TRAB or AGV, whatever you can do if pressures are out of control, and then jump in for a PRP or PPV. If media is bad, then vitrectomy. If media is good, then laser. So my conclusion is that in these patients you need to walk an extra mile, document it well to safeguard you and your patient, give some extra chair time to the patient and be prepared for surprises. Thank you.
Thank you, Dr. Mohit, for giving a very wide overview and giving the warning.